So thank you to Astelas and to Morgan for the invitation. I hope you have still enough energy for this last presentation. So during the next 20 minutes, we are going to talk about how to use new hormonal therapy in clinical practice. And we will start with a real patient that we will name Mr. C. He's 65 years old. He has been diagnosed with cancer in 2010. It was a high-risk localized prostate cancer treated with radiotherapy and ADT. He had a biological relapse in 2014 without any metastases. Again, he was treated with ADT and he became castration resistant in 2016 with occurrence of lymph node and bone metastases. His only comorbidity is hypertension that is well controlled with just one treatment, and you want to start new hormonal therapy, either abiraterone or enzalutamide. I will emphasize 3 points that are very important to me. First is medication compliance. Second, the side effects, the importance of informing the patient, how to follow them, how to prevent them. And of course, efficacy. When can we evaluate it, and when do we have to stop treatment for progression? So first, with medication adherence. I think it's very, very important to take the time during the first consultation to explain correctly to the patient how to take those treatments. With abiraterone, it's 4 pills in a single daily dose at a fixed hour, but not during meal. Why? Because food increases the absorption of abiraterone. So the patient must not eat 2 hours before and 1 hour after. You also have to prescribe prednisone to prevent side effects. You can prescribe 5 milligrams twice a day or 10 milligrams once in the morning. I personally prefer 10 milligrams in the morning because if they take corticoid at the evening, sometimes it can make insomnia. With enzalutamide, it's more simple because it's also 4 pills in a single daily dose, but they can take the treatment whenever they want. Food does not impact on absorption. The inconvenience is the size of the pills because they are a bit larger, almost 2 centimeters. So sometimes it might be difficult, especially for patients that are old, and you can advise them to take it with food, for example, a yogurt. The second point that is very important and that have been said previously is that you have to explain them that those treatments doesn't replace ADT and they need to continue their LHRH analog during the treatment. And the last thing is that unfortunately we do not have biological marker like testosterone for LHRH analog to check if the patient take correctly the treatment, so it's very important to check that during each consultation. About side effects. First, of course, it's important to inform the patients. With abiraterone, you might have hypertension, edema, cardiac failure, hypokalemia. All of those treatments are related with the increase of mineralocorticoid and are prevented with prednisone. You also might have cytolysis. It's rare, but you need to follow hepatic enzyme during the first 3 months. And you also might have side effects of prednisone, immediately, for example, hyperglycemia. And you can also have osteoporosis, especially in patients that receive the treatment for a long period. With enzalutamide, you can have asthenia. However, it's less frequent asthenia if you prescribe it previously to chemotherapy. You also might have hypertension And there are cases of seizure that were reported in the 2 phase 3 trials, PREVAIL and AFFIRM. However, the data of the real-life patient in this phase 4 trial reported that the incidence of seizures in patients treated with enzalutamide was more or less the same as the incidence in the general population. So you have to inform the patient, but keep in mind that it's very rare. Next, how to prevent those side effects. I think that the first thing important is to give the right treatment for the right patient. For abiraterone, avoid it if the patient has a cardiac dysfunction or uncontrolled hypertension. With enzalutamide, you have to avoid to prescribe it if there is history of seizure or risk factors of seizure, for example, chronic alcoholism or history of strokes. And the second very important point is the co-medications, because there are a lot of interaction with abiraterone or enzalutamide with other very frequent treatments. For example, oxycodone for abiraterone or Bactrim, Plavix, warfarin with enzalutamide. And as it is very hard to know by heart all of those interactions, I think that first you can just ask your pharmacist. And if you don't have a pharmacist, you can also check on the internet. There are websites and also smartphone applications. But it's important to think about that. And for the follow-up, well, with enzalutamide, it's quite simple. You have to see them after 1 month for a clinical examination. You are not, this is not recommended to see the patient with a biological exam, but I personally prefer just a simple exam with CBC, platelets, electrolyte test. And after that, you have to follow them every 3 months. With abiraterone, the monitoring must be close during the first 3 months. It's every 2 weeks for clinical examination to check if there is no side effects related to mineralocorticoid increase. And also you have to check hypokalemia and, of course, hepatic enzyme. After that, Janssen recommends to see the patient every month, but I think it's probably too much, and every 3 months is okay for the follow-up. So this is just a summarize of what I've just previously said. And last but not least, efficacy. What are the timelines for evaluating it, and when do we have to stop the treatment? And I think it's very important. So when can we evaluate it? I think that it's very difficult before 3 months of well-conducted treatment. How, well, you can have clinical signs of efficacy, less pain, less asthenia, more appetite. You can also have a biological sign, decrease of alkaline phosphatase, and of course PSA. Contrary to what happened with chemotherapy, PSA flare-up with new hormonal therapy are pretty rare, less than 5% of the patient, and probably the PSA at week 4 might be a good predictor of response after 3 months, based on this retrospective study conducted in CRPC patients treated with abiraterone. Among the patients that had PSA decreases of more than 30% at week 4, 70% of those patients had a biological response at week 12. About radiological exam, I think that we have to do CT scan, bone scan, but not choline or PSMA PET. Those 2 exams are very good for the staging, but I think that there is insufficiency data to advise to use it for efficacy. Moreover, it's more expensive and not available everywhere. And next, when do we have to stop the treatment? And I think that this is probably the most important slide of my speech. If PSA increases, there is no rush. It's very important to take the time to check if the patient has clinical progression or radiological progression. And as you know, EAU guidelines made a clear definition of progression. It's at least 2 criteria among clinical deterioration, PSA progression, and radiographic progression. Based on that, you have to follow the patient every 3 months, as I've just said before, and you have to do a radiological exam every 6 months, even if the patient has no sign of progression. Why? Because 5 to 10% of the patients might have a radiological progression without any other sign of progression. For CT scan, the definition is clear. It's based on RECIST criteria. And for bone scan, the definition is different. It's the rule of 2 plus 2. So patient must have 2 new lesions on a first bone scan and 2 other new lesions on a second bone scan compared to baseline. And after that, you have to ask yourself, does the patient still benefit from the treatment before stopping it? A new concept has been introduced by the PCWG3 that is the no longer clinically benefiting, because probably you can continue the treatment if there is just a slow progression of PSA and or a slow progression on imaging. And I think that to make the good decision to stop or not to stop, you have to distinguish different situations. The type of progression, it's probably not the same if there is visceral metastasis occurrence versus the progression of the known lesions. It's also very different if the patient is symptomatic. And I also think that it's different if there is a primary resistance to new hormonal therapy versus secondary resistance, because we know that some patients have primary resistance, and I'm not sure that those patients may benefit of continuing the treatment. So this is my last slide, the take-home messages. The first is choose the right drug for the right patient to avoid side effects. The second is the importance of close clinical and biological monitoring during the first 3 months, especially with abiraterone. Be careful with the medications. The co-medication, because there are a lot of interaction, and do not stop new hormonal therapy just based on a PSA progression. Thank you.
Thank you, Constance. Please come with us, join us. We'll discuss a little bit this aspect of daily life. That's quite important because, as mentioned by Guillaume earlier on, there are many options when we discuss prostate cancer cases. But in fact, on the paper there are options, but in the reality of the practice, there are not that many options that are available for, I would say, the whole population, many centers. And I think we are lucky in France to have the ability, as urologists, to prescribe the drug because we can deliver the enzalutamide. Is it the situation in Italy? So how do you do? Yeah, okay.
We just had quite a strong discussion with the regulatory authorities in Lombardia, the region where I live, where Milano is located. But the answer was negative in that the position of the Italian government is that every single patient should be discussed during tumor boards meetings, and they don't care less if the new Latitude trial and the rest has been published, so that the medical oncologist is the one who is making the prescription. So we discussed the cases all together. That will not be possible in every single case due to the number of patients who come in, especially in a place like ours. So I do not know exactly what is going to happen.
Thank you. That's a point. What is important for the French, I would say, French urologists and many other countries where you have the ability for the prescription, because we have been. We have seen that in daily practice it's quite easy to deliver. There are, of course, tips and tricks and good points to mention to the patient in terms of, I would say, medical education. But it's quite easy and friendly to use. And I think that's we should be aware of that, because there are many options that are technically sophisticated when we think about Sipuleucel, for instance. So when it comes to enzalutamide, for instance, it's quite easy to prescribe in daily practice. In France, you need to have the ability to deliver oncological drugs, but since there are many urologists that can do that. Alexandre, in your practice, can you grab the microphone? What is your feedback with the use of these pills? Did you have some patient that came back to you and said have difficulties because she showed and she spent a lot of time demonstrating the size of the pill? It can be an issue for the patient, the volume of the drug. And
well, for the moment, no. I have some patients who complain, but they usually take the pills. What about in your experience?
I had a problem with an old patient because it's 4. Just one, it's okay, but 4 pills at one time, it might be difficult, I think. But you can advise them to take with the food, and usually it's okay.
Yeah, I would say that in most cases there is no problem with that. Guillaume, did you have any issue with that matter?
No big issues. I think they are complaining, but they're taking the pills.
Yeah, but when you look at the volume of prescription in France and the patient is coming to your office, most of the time he has already a list that is very, very long of pills. So we can spend time to eradicate some pills that are totally useless. This one obviously is a very serious option, and the observance is quite good, and there is no issue with that. Okay, I think we are going to close this session. We need to thank again very strongly Astellas for the support and the support of this event and this very interesting session. We have the opportunity to exchange together with people from different landscape, medical oncologists, colleagues from outside France, and thank you again Astellas for this symposium. We will connect, if you don't mind, with Henri Mondor, because the poor Bonchalacombe has a feeling to be an orphan, to be abandoned, and it is not true, because we were live also with him. Can we connect with Ben just to tell him that he is not alone?